Thank you everyone in joining today for what we think is going to be a very informative and engaging discussion about the NeuroPace RNS system. As you heard, my name is Michael McKenna, and I'm a NeuroPace patient educator. In disclosing just a little bit about myself, I was diagnosed with epilepsy over 25 years ago, and I've been living with the RNS system for over 12 years. And just so to get it out of the way now, so you guys try to figure out where my device is right here. Today, we also have the privilege of having Dr. Marty Morrell, who's an epileptologist at Stanford University, and is also the Chief Medical Officer at NeuroPace. Dr. Morrell will be providing her clinical expertise on the RNS system, including an overview of how the RNS system works and the clinical use of the RNS system for patients with drug-resistant epilepsy. We'll have time for your RNS system questions after we hear from Dr. Morrell. And if you have a question about your specific medical diagnosis, we kindly ask you to please direct your questions to your epilepsy specialist. So I'm now going to turn today's RNS discussion over to Dr. Morrell.
Thank you very much, Mike. And I hadn't quite realized that it's about half of your epilepsy journey. You're coming up to the 50% mark. Let me introduce myself. I am an epilepsy doctor, and that's what I have done since I finished my residency in neurology and my fellowship in epilepsy and EEG. So it is a very long time. And I've had the opportunity all of my life to take care of persons with epilepsy, but also about a little longer than Mike has had the RNS system. Beginning in 1997, I became involved in a project to develop something that was not more medications and that was not epilepsy surgery, because although those treatments are very effective for many people, they are not for some. And it is those some people that are really a challenge. And I felt that by developing an entirely new way of treating epilepsy, I might help meet that challenge. So I mentioned that I'm an epilepsy specialist. Epilepsy specialists are individuals who have had generally years of training after they complete their neurology training. And oftentimes it is in reading electroencephalograms and in treatment of epilepsy. And that would include treatment with all of the medications, treatment with epilepsy surgeries, and now treatment with neuromodulation. And of course, we have 3 neuromodulation devices currently, the VNS, the DBS, and the RNS system. These are for people whose seizures cannot be controlled with medication and who are not candidates for highly effective and safe epilepsy surgery. So of the 3.4 million people in the United States who are living with epilepsy, about 30% of people are not, have not achieved a satisfactory response. And this is the target patient population for the RNS system. Now, if you have drug-resistant epilepsy, you should be seeing an epilepsy specialist. Well, what is drug-resistant epilepsy? We know that fortunately most people's seizures are controlled with the first anti-seizure medication or maybe the second anti-seizure medication. But if 2 medications that are appropriate for the seizure type and are provided at sufficient doses have not achieved the treatment response, then it's time to see an epilepsy specialist and to consider what other options exist. And so the first step, of course, will be diagnostic treatment. And that may include sophisticated EEG monitoring. It may even include EEG monitoring in a specialized epilepsy center in the hospital. It might include advanced neuroimaging, including MRI scans on supersensitive MRI scanners. It may include neuropsychological testing. There's a great deal to offer in a comprehensive epilepsy center, including expertise on all of the anti-seizure medications and expertise on surgery and neuromodulation. And yet, only 1 in 5 people who have seizures that are not satisfactorily controlled on medications are actually being seen at a comprehensive epilepsy center. And so this is, really unfortunate and concerning and hasn't changed in 15 years. Well, the first consideration is what type of epilepsy an individual has. And we generally think about it very simply as falling into one of two types: focal seizures and generalized onset seizures. Focal seizures are those that begin in one part of the brain and then may spread. And depending on the extent of the area involved with the seizure, that will determine the types of symptoms that occur. Um, Generalized seizures, on the other hand, are seizures that begin all over the brain at the same time. And usually those impact the individual all at once at the same time, and may be absence or petit mal seizures, or may be generalized seizures such as sudden drops, or seizures characterized by sudden stiffening, or generalized tonic-clonic seizures. The reason it's important to know the difference is that there are different treatments for each of these epilepsy types, both different medications. Some are more effective in one type of seizures than the other, but also options like surgery. Well, what about other options? We've talked about epilepsy surgery, and now we want to talk about neuromodulation devices, and specifically the RNS system. How does the RNS system work? It has really 3 components to it. And if you think about, you probably have a relative or a friend with a heart pacemaker, it's not completely dissimilar to that, in that it is monitoring, in this case, the brain electrical activity all of the time. It has been programmed by the physician to recognize and respond to patterns unique to that individual that herald or precede seizures. When it detects that, it will provide responsive pulses of stimulation that are not felt. And then it records that activity so the physician can go back and look at the records and see what has been detected and what the electrical response has been to stimulation. And Mike, maybe I'll say next when it's time for the next slide. So okay. Next. So this works very well because it's quite doable to program the device to recognize the patterns that are unique to an individual. And once these patterns are recognized, they are the same. So tuning it in or personalizing it for each individual is not difficult and can be accomplished within several months. And at that point, the job of the physician is to adjust the way that stimulation is delivered, to fine tune that to the treatment. So this is truly personalized treatment. And the device allows us to learn and to apply those learnings in real time over the course of treatment. Next slide. There are over 2,500, actually just about 3,000 people now who have been treated with the RNS system. The clinical trials that led to FDA approval began in 2004. So there's a very long history. And in those studies, some patients were followed for over 9 years. In fact, over 200 patients followed for 9 years. And this is available to individuals who are interested at most of the comprehensive epilepsy centers in the United States. This is actually close to 180 comprehensive epilepsy centers, so almost all of them. And it is recognized as an effective treatment by insurers, and that includes both private insurers and government insurers such as Medicaid or Medicare. In fact, of those individuals who have wanted to be treated by the RNS system, 99% have received coverage by their insurer. Why is that? It's because the insurance companies recognize that uncontrolled epilepsy is a very concerning medical condition, and recognize the RNS system as not only a very effective treatment, but a treatment that retains its effectiveness over time, over years. If someone is responding to the RNS system, it does not wear off. And unfortunately, that has been the experience for some individuals with some anti-seizure medications, that there may be an excellent response for 6 months or so, but then that response becomes not so good. But that's not the case with neurostimulation, which really retains its effectiveness. The next slide. So what are the results with the RNS system? I mentioned that in the studies that FDA used to base the approval, there were individuals followed for over 9 years and 256 patients who were initially treated beginning in 2004. There has subsequently been a group of epilepsy centers who have treated a large number of patients with the RNS system, who ask themselves, well, now that we aren't in the semi-artificial environment of a clinical trial, but now that we're in the real world, how well does this work? And so these are called real-world studies. These studies found that there was a reduction of 67%, a median 67% seizure reduction at 1 year of treatment, and a median 82% reduction at 3 years. Well, these numbers, the 67% is really good, and the 82% is really, really good. And this is part of what I mentioned, that neuromodulation is different than anti-seizure medications. You should see a response very early on in treatment, but that response continues to improve over time. This is a consistent finding in all of the experience with the RNS system. A third of patients had a greater than 90% seizure reduction at the last time of follow-up, and 39% of individuals had had at least one period of 6 months or longer without seizures. These results you may recognize them as even more meaningful if I tell you that the average number of seizures was about 10 per month, and the average duration of epilepsy was about 15 years. So these individuals had a real challenge in controlling their seizures. The next slide. What are the other results? Because of course, seizures are just one part of the story. And it's extremely important that any therapy that is going to be used affect quality of life. And the RNS system, as part of the trial, quality of life has been monitored very closely. And there are statistically significant improvements in overall quality of life. But if we drill down and say what areas of quality of life show improvements, they include mood, physical health, the ability to think and concentrate, cognitive function, mental health, and then also worrying about seizures. These are very important because some of these are negatively affected by some of the anti-seizure medications, which may have negative effects on mood or cause irritability, and some may cause sleepiness or fatigue or slowing of thought processes, certainly not all. But this lack of side effects and in fact improvements is something that is a very strong plus for neuromodulation and the RNS system specifically. There also are no side effects associated with the neurostimulation. It's not felt. And of course, some people, definitely not all, but some people may have a perception of stimulation with the VNS, and the physician will try to get rid of that by programming the device differently, but it can happen. People might worry about the risk of infection of having a device placed. But that risk of infection is low. It's less than 4 out of 100 people. And that's related to when there is an incision to place the neurostimulator, which is located just within the skull and attached to leads that are placed at each individual's seizure focus. These are generally infections related to the incision, just the same as the risk for infection with an appendix removal or any other minor surgery, and are about half the time treated with antibiotics, and the other half the time the system may need to be removed. But that's really the risk that if you're interested in this, these are the types of side effects that you can discuss with your physician. I believe that most in joining us today know about the horrible phenomenon of sudden unexplained death in epilepsy, or SUDEP. Fortunately, this is very rare, but it can affect, and has been shown to affect, about 6 out of 1,000 patient years, or occurs in 6 out of 1,000 patient years in the studies of anti-epileptic drugs for those persons who have been randomized to the no drug arm. So really kind of continued treatment. The RNS system has reduced that SUDEP rate to 2 per 1,000 patient years. So a threefold reduction. And of course, this is fabulous. And we believe that anything that further reduces seizures, even if seizures are not eliminated completely, but if seizures can be reduced, then they reduce the risk of this catastrophic event. The next slide. Are you a candidate for the RNS system? Well, the RNS system is approved by the FDA for individuals who are 18 years of age or older and who have failed to adequately respond to 2 or more anti-seizure medications used either alone or in combination. It is approved for those with partial onset seizures, and that's because the device is detecting and recording from one area of the brain or 2 areas of the brain. And so it is not at this point indicated for seizures that occur from all regions of the brain at once. And then, of course, you will be interested in the RNS system if your seizures are impacting your quality of life. Of course, each individual has their own story. And so really it's a conversation with the physician that will help any individual who is thinking about the RNS system decide whether it is the right choice for them. The next slide. Well, the RNS system does not take away the need to use medications. It is used in conjunction with medications, although depending on the individual's response, it may be possible to reduce medications or either by reducing the dose or even taking some away. It is a reversible therapy. If it is tried and it doesn't work, it can simply be turned off, or if desired, it can be removed. But it does not involve any removal of brain tissue. The leads or the electrodes are placed in the brain at the seizure focus, but there is not any removal of the seizure focus nor destruction of the tissue around it. So the safety of it is very good. And if someone is thinking about having an epilepsy surgery but is offered the RNS system as an alternative, it is possible to do one first and then the other. The epilepsy team will conduct testing to find out where the seizures are coming from. And you see in these diagrams below the pictures of the brain, and all of these brains are looking to your left, and there's a lot of experience treating all types of partial onset seizures, really in every region of the brain. And so your physician will look to that experience, determine where the electrodes should be, and also Your physician will be able to counsel you based on the extensive information from the clinical trials about what the odds are for you of having a meaningful seizure reduction, and in fact, what they anticipate that reduction to be. The next slide. Well, let's talk about the procedure. The neurostimulator, which is really a little computer with a battery, is placed within the skull. It does not touch the brain, and it does not sit above the skull. So it was designed to be the same thickness as the skull and to curve in the same way that the skull curves. Because it sits in a tray, that little tray is got tiny little screws that lock it into the skull. So that neurostimulator is not going anywhere. It is firmly affixed. It doesn't create a soft spot that puts anybody at risk for it bouncing or moving. The leads are tiny wires, and those wires are placed according to the seizure focus. In the illustration you see there, this is somebody whose seizures begin in the temporal lobe. The physician and the epilepsy team have decided that that is the region, that is the problem area where the seizures are coming from, and has placed those leads there to monitor that region all of the time and to provide stimulation in that location. The procedure is done by a neurosurgeon in the hospital under general anesthesia, and most people stay overnight in the hospital, generally one night, and go home the next day. There's no brain removed, so this is not the type of procedure that, or the after effects of this are not at all like they might be for somebody who's had an experience with phase 2 or intracranial monitoring or even an epilepsy resection. The current device, the battery lasts about 8 years. And when it's time to be replaced, there is a little incision in the scalp where that neurostimulator sits. The neurostimulator is lifted out of the tray, and a new neurostimulator is plugged into the leads that are already there. So the leads are not removed, they're there. And it's put back into that tray and just locked into place. The incision is closed. It takes about 45 minutes, and it's done as an outpatient. The next slide. What is it like living with the RNS system? Well, Mike is going to provide you his perspective, but I'll talk to you about it from the physician's perspective. When the device is placed, it is turned on to detect and to record. So it starts immediately to gather information about the electrical activity in the region where the leads are placed. And then usually the person being treated will return to see the physician at 2 to 4 weeks. And at that point, the physician will look at all of the information which is available to the physician and will decide whether the detection is appropriate. I saw a patient yesterday who just had his RNS system placed a month ago, and I was able to look back at all the data that had been recorded from that month, and I saw several seizures, and I adjusted the detection to match the particular signature of that individual, and said, okay, now we're ready to turn on stimulation because I feel very good about what we're detecting. I am able then to talk to the device with a wand that's just held over the device about an inch or two, and that gives me all the information from the neurostimulator. But in addition, when a person gets the RNS system, one also gets what's called a remote monitor. It's a laptop that only does one thing. It collects information from the neurostimulator. At home, there is also a wand that's held over the device that pulls all the information from the device. It's not, you don't feel anything. And then it sits on the remote monitor, and then about once a week, that's plugged into an internet portal, and all of that is sent to a secure database that I as a physician can review. So I have a password, it's my password. I can go into this database, which is called the Patient Data Management System, and all of the information for all of my patients is there. So for another patient I saw yesterday who has been treated for 3 years, I am able to see everything that has happened over the 3 years. And this is very powerful because it allows me to see when I make changes, what the effect has been, and I can compare it to other times. Now, initially, when the stimulation is initiated and when some early changes are being made, well, really it's when detection is being fine-tuned. Your doctor may ask you to come in about once a month, but then very soon it'll be once every 3 months, and it might even then move into once every 6 months if everything is stable. Now, you can get an MRI scan with RNS 320, which is the current device, under certain conditions. You can get an MRI scan of the brain and of anywhere in the body. The radiologist or the radiologist has access to the information that tells them exactly how to get the MRI in terms of how to set the MRI parameters. The next slide. So I'll stop there and see if we have any questions before we get Mike's input as a patient who is being treated. So here's a question, and Mike, I can't see it all, but well, maybe I can. Let me see. The question is, how do we adjust the device to personalize the stimulation? And a second question is, if you want to remove the stimulator in the skull, what is it replaced with? Well, let me answer the first. So the physician has a programmer, and this is how I talk to the device. I will look on my programmer or on the patient data management system at all of the recordings of the brain activity from my patient that has been obtained by the RNS system. And I know from my training as an epilepsy specialist what's normal and what's not normal. When I see what is not normal, I will decide whether that is something that I want the neurostimulator to detect and to provide stimulation and response to. Based on that, I mark what that is, and the device will then determine how it needs to be programmed to make that detection. Or if I want to get fancy about it, I can set all of that myself. But this is something the doctor knows how to do. Now, if somebody would like to have their neurostimulator removed from the skull, then generally what is done is the tray is left in place. It's designed to be left in place forever. And where the tray was is filled with it's kind of like a plastic. It's called methyl methacrylate. And it replaces the skull and becomes very smooth. So that's usually what the neurosurgeon will do. The next question is there a parameter for how many seizures per month the patient is having in order to be considered for the RNS system? The studies, the trials, require that patients have at least 3 seizures per month in order to be a candidate for the study. And that is what the labeling or the official FDA indication for use says. It is up to you and your physician to decide whether you are impacted by your seizures in a manner that that makes the RNS system of interest. So, people have different types of seizures, people have different types of lifestyles. And so really, that is a discussion to have with the physician. The next question is, do you have to do phase 2 testing in order to place an RNS, or is phase 1 enough? So for those of you who are not familiar with this, our shorthand is that phase 1 monitoring is an admission to an epilepsy monitoring unit with electrodes placed on the scalp for continuous video EEG monitoring. So this testing is done in order to record the brain electrical activity, the EEG, 24 hours a day. It's usually done for several days, maybe as long as 2 weeks if necessary. The intent being to record seizures. This allows the team to understand how one is affected by seizures because there is a video. So, what are the changes with the seizure? And then also to see what the changes in the electrical activity are in order to pinpoint where the seizures begin. For some individuals, that may not be sufficient to know with enough certainty where the seizures come from. And in this case, it may be necessary to slip electrodes underneath the skull. And that would be electrodes in generally more in the general region that is in question, or that is thought to perhaps be related to the seizure onset zone. These electrodes can be strip or grid electrodes that are placed on the surface of the brain, or they can be depth electrodes, which are needle-like electrodes that are placed within the brain. This may also be done because there's a question of whether the area from which the seizures arise, whether it would be safe to remove that area. And in that case, this is done in order to do brain mapping, which is to provide brief stimulations and while being neurologically tested to see if that area is responsible for language or movement or sensation. It is not necessary for many patients to have that phase 2 monitoring. In the studies, about a third of patients treated did not have phase 2 monitoring. Now that it is being used in the real world, there are fewer people who have phase 2 monitoring before going to the RNS system. Generally, people whose seizures begin from the temporal lobe are those individuals who may not need phase 2 monitoring. But this is really something that the epilepsy team, the whole epilepsy team, including the neurologists, the epilepsy specialists, and the neurosurgeons will decide. The next question is, will the captured data from the RNS system help in finding more effective medication combinations? Well, I'm very happy this question was asked because this is something that we really just stumbled upon a few years ago, that in fact we can tell by looking at all of the brain electrical data that is coming in, that oftentimes we can tell whether there are good changes or not so good changes from adding a new medication or taking away medication. And let me refer to two papers. One paper was done by Dr. Taras Skarpis, who is a senior scientist at NeuroPace, and the second one by Dr. Karashi at Yale. These are both published. And these papers showed that if you look at the brain data recorded by the RNS system, that within 2 to 4 weeks, you can see changes that are that indicate with 80% likelihood about whether that medication is going to be effective. And these are changes in some of the discharges that are picked up by the RNS system. Now, the other side of it, and there's not a study on this yet, but I have a lot of personal experience with this, is that sometimes because the epilepsy is so bad, my patients will be on 3 or 4 medications by the time they have the RNS system, and they often come to me on all of those medications. And so we're always very interested in seeing if we can take some of those medications away. But of course, if somebody's doing really well, you're nervous about tipping that balance. So using the RNS system data, I'm able to gently withdraw a medication and monitor the EEG data to make sure that, that everything is fine. So it makes me more comfortable, and more importantly, it makes my patients more comfortable about the medication withdrawal. Another question is, are there new advances planned in the future for the RNS system device? And is there an outlook on a 4-lead device? So there's always work being done to create additional capabilities. And of course, the engineers at NeuroPace do not sit idly by. I will tell you that this is a highly regulated therapy by the FDA because it is a device that is placed within the body. And so any change to the device, even a change that one might think is, well, that's not a big deal, is always a big deal and has to undergo significant scrutiny by the FDA to make sure that it's not going to compromise the safety or the efficacy of the device. So changes don't happen quickly, but there are, of course, plans to make hopefully the device last even longer. And there is an intent to develop a device that can be connected to more leads. But, you know, frankly, the capabilities of the device right now are so powerful that really our challenge is to understand how to use all of the things the device can do better and better. One of the questions is, can the RNS system provide constant stimulation similar to a deep brain stimulation? Well, the RNS system is very small. And in order to be very small, it does not have a big battery. And because for the DBS system, the battery is placed in the chest, it is a big battery. So the RNS system cannot provide continuous stimulation and last 8 years. It can provide stimulation fairly frequently, but there's always a trade-off. So the more stimulation that is provided, the shorter time it will be before the battery needs to be replaced. This is something that can be discussed with you and your physician. If your physician feels that it would be best for you to have more stimulation, then it would be possible to tell you how long it would be before the device would need to be replaced. Another question is, how specific does the focal point have to be in order for the leads to be placed? And then the example is for epilepsy surgery, the focal point has to be narrowed to the exact millimeter. Is that the same for the RNS system? Or can the leads be placed to cover a few millimeters or a centimeter? Well, we've learned an awful lot over the years. And now we're recognizing that, that it doesn't have to be defined within, certainly within millimeters, or maybe even much within centimeters. And there's a paper that came out recently from University of California, San Francisco. The senior investigator of this was Dr. Vikram Rao, that showed that for some individuals, having the leads placed as far as 11 centimeters apart, which is about like this, allowed the patient to be very well treated. And what happens, of course, is that there are 8 individual electrodes across those 2 leads, and each electrode can provide stimulation or not, whatever the physician wants. But by changing the electrodes that are involved in delivering the stimulation, the physician can alter the territory that is affected by the stimulation. So by programming it, the territory affected can be tiny, if that's the desire, or it can be broader. So although we really want to know the area, and it needs to be 1 or 2 areas, that's where the leads can be placed. As long as there's a detection early in the discharges, the stimulation can be over a broader range. And I believe that that is the last question. Is that correct?
Yeah,
wonderful questions. Wonderful questions, and thank you for the opportunity to answer those. And now, Mike, should we move on to you sharing your experience?
Yeah, I'd like to, some of those questions I've definitely been through down that journey. I mentioned at the beginning of the presentation, I've been living with epilepsy over 25 years. I went through many, many years of medications. Very early on, my doctors, the word epilepsy was never in the conversation. It was, my doctors were thinking possibly I was having heart issues. So for the first year, my doctors really concentrated on my heart, thinking I had something wrong. So I was still working, still driving, epilepsy, seizures. I had no clue what that was until I eventually had a auto wreck and woke up in the ER in the middle of the morning, like at 1:30 a.m. and I was told I had a seizure, and the focus then switched to epilepsy. And I was just kind of like, what is epilepsy? you know, I didn't have any clue. Lost my driver's license that night. And so then I went on the journey of trying to find medications to control my seizures. I went through a lot of years of being at very high dosage of medications, uncontrolled. Eventually, my um, secondary generalized seizures were happening every 3 to 6 days. The type of seizures I had on those grand mal seizures was my body would tighten up really, really tight. And I would break bones, dislocate joints. So I have a prosthetic, like right shoulder, a couple of replacements, bone fusions throughout my body, um, broken neck, broken back. Um, I had a demand pacemaker that was put in to restart my heart because paramedics and ER doctors discovered that my heart did stop during the seizures. So I had that put in. Um, so my life was pretty bad up, pretty bad. Um, Eventually, I was lucky enough to get referred up to Mayo Clinic in Rochester. And so I was traveling from Northern California to Rochester, and my doctors up there put in VNS. So I tried VNS therapy for about 2.5 years, and for my seizure type, it didn't work for me. I was still having those secondary grand mal seizures every 3 to 6 days. Um, and so eventually I moved to Mayo Clinic in Phoenix to be next to my doctors at Mayo Clinic. And I thought I was just going to go down there really quick, get fixed, and then go home. And, unfortunately, I was there for 13 years with my doctors trying to figure out what to do. Um, then came the conversation about resection surgery. So during the phase 1 testing through the years, my doctors thought that my right temporal lobe was where my seizures were coming from, where the focus was. So I was in the hospital for 14 days. I had grid mapping done. This was a long time ago. So for 14 days, of course, I didn't have a single seizure. So it was a long stay. The morning of the 14th, my doctors came in and they were super excited that they captured right temporal lobe activity. So they were going to schedule surgery the following morning. I was excited because, I was told that that would be the seizure cure for me. My doctors came in that afternoon and said they had bad news that since that morning, my left temporal lobe was showing all kinds of activity. So they canceled that resection surgery. Um, that was really discouraging to me because I thought that was going to be finally the cure. I was discharged from the hospital. There was, I had tried everything else out there. And that was actually a good moment in my life, even though it was discouraging. I also changed my mindset. I realized that I could no longer let epilepsy dictate my life. I needed to be in control. And so I decided to take back my life and go to college, um, to figure out what I could do. During my early college career, my doctors at Mayo Clinic in NeuroPace asked if I might be interested in the RNS clinical trials. And, at that time in my life, I knew my seizures were really bad. I wasn't expecting any other type of treatment to work, but at the same time, I knew that, at least Mayo Clinic and NeuroPace would have some awesome brain data for future patients, and I was like, sure, I'll try it. I'm not sure what it's going to do. Um, that was really a change in my life because, the RNS system with the data that's collected really gave me back a voice with my doctors. The data kind of validated what I had been trying to explain to my doctors for, over a decade, and finally I had this data that said, yes, I did have a seizure 2 weeks ago, and that was really empowering. And, I was also able to keep track of my seizure activity through a seizure diary. And we discovered things in my life that were seizure triggers, things like we discovered heat stress in Phoenix. Anytime I got to 110, 115 degrees out, if I was out in that heat, I would get really tired, fall asleep, and have a grand mal seizure. Together with my diary and the RNS data, that allowed me to adapt my life to avoid the afternoon heat. We also discovered in me that high carbs was a seizure trigger for me. I was on disability, which meant I was always broke and always starving to death. I didn't have money for food. And one of my go-to meals was a couple of plates of spaghetti and like a half a loaf of Safeway French bread, because it filled me up. It was super cheap. But about an hour and a half after a meal like that, I would fall asleep, have a grand mal seizure, come out of it, again, put it down in my diary, brought that with me to my appointments, which, as Dr. Morrell mentioned, was every 3 months. Having that information, I adapted my diet. So I removed another trigger from my life. During this whole stage, I was in college, and I was able to see the improvements in my cognition and memory, to where I eventually graduated with a graduate degree in social work. And I also enrolled in the Mayo Clinic School of Health Sciences and got a dual degree, and even worked at Mayo Clinic in Phoenix as a social worker, together with all my doctors that had been treating me through all those years. I would be doing rounds on the team, and my doctors would just be shaking their heads thinking, what are you doing here? Like on this side of the counter, like, oh my gosh. And so, I was able to see that improvement over time. We talked about medications. And so we were able to use my RNS data to get me off of 3 really bad meds that I was always in the toxic levels. I was always having lab work done to make sure my liver wasn't going to shut down. And so I really wanted to get off of those meds. So what we did for me was we said, okay, let's go ahead and take your Dilantin, cut that dosage by 25% once a day, and then kept me on the same levels of Neurontin and Ativan. And then we also started me on a new medication called Onfi at 10 milligrams once a day. And then my doctor sent me home, and for 3 months, we just let my RNS system collect its data. And at my next appointment, we saw no increase in seizure activity. So we knew those changes was safe for me. We also knew starting me on Onfi wasn't going to cause me seizure activity. So the next step was we said, let's go ahead and cut your Dilantin by 50%. And then they took me off of Neurontin and Ativan, raised my Onfi to 20 milligrams once a day, and then again, sent me home. And for 3 months, let RNS gather its data. And at my next appointment, we saw no increase in seizure activity. So we knew all those changes was safe. So took me off of Dilantin, and right now I'm on 15 milligrams of Onfi once a day. And that's how we use my RNS data to manage my medications over time. So between my medications, finding my seizure triggers, adjusting my overall epilepsy and wellness care, I've been seizure-free now, clinically seizure-free for about 8.5 years. So I work full time now. I'm off disability. I do drive. So I lead a kind of a normal life now. So it was really the RNS data and the way it's personalized was really empowering and impactful in my life.
I'd like to add, Mike, that this being able to in the clinic room, turn that computer screen around and look at all of the information from the RNS system together with my patients is just such an extraordinary experience. So I can say, it looks like there was an increase in activity around this time. Did you experience anything? And then my patient will look at their diary and say, yes, that was something. Or I'll say, the evening of whatever, I think I saw something, and they'll be able to say, I woke up that morning and I didn't feel well. Or, and this usually happens with my teenage patients, I'll say, you've been doing really, really well. And then all of a sudden things didn't look so good. did you stop taking your medication? And then, you know, we all hear about the individuals where this happens, and they'll say things like, well, my mother-in-law came to visit and I can't, you know, I have a really difficult time when she's there.
Yeah.
So this communication is very helpful. Also, the physician can review the data even if you're not there, because you are sending the information over the internet. So another thing that I will do is if somebody is not feeling so well, I'll say, wait a second, and I will go through and over the telephone or over our, you know, secure email system in the hospital, look through and, you know, we can talk about what's going on. Or many of my patients come from a long distance, and the device, if you're going to change the settings, that does need to be in clinic. But I review this data, and then I may just talk to somebody over the telephone and say, you know, everything looks great. I don't feel like I need to make any changes to your programming. So let's just talk about how you're doing. And I'm not going to make you drive 4 hours to come and see me. So all of that is it's just, it kind of makes me feel like I've been treating people as a black box, you know, because of course it's so hard to know how many seizures you've had, and many seizures occur during sleep. And so now finally there's actually a number. And then if I change a medication, I can, the most important thing, of course, is what you experienced, Mike. But that is supplemented by the information from the RNS system.
Can you
you know, Mike, let me ask you a question, because I know you talk to many people who are thinking about the RNS system, and maybe you can share some of the most common questions, and then also some misconceptions about people who maybe have been introduced to it, but maybe they've been told something a little wrong or a little confusing.
Yep. So some of the misconceptions out there is, for example, like prior VNS patients or patients that currently have VNS, they hear the word RNS and they think it's the same thing, the same type of therapy. And so one of the questions that they ask is, why should I put the cousin of VNS into my head? You know, which is a valid question. Another question that gets asked is, I have VNS, I don't want to remove it. Can I still get RNS? Can I use them together? And you can use both therapies together. I do encourage the patient, you know, to talk with their doctors about those questions. The recovery, you know, sometimes a patient that might have had a prior resection surgery, the recovery could have been very long for that. And so when they hear that RNS requires a surgery also, they relate the two together, that if they get RNS surgery, it's going to be the same 6-month or 1-year recovery, and it's not. I was in the hospital for 2 nights, and I was back in college a week and a half after being discharged from the hospital. So the recovery is pretty quick. There's not much burden or anything for a patient to have to live with the RNS system. You know, you hear, patients might hear, oh, I got to interrogate, I have to have a laptop, I have to do this. You know, once a day in the beginning, this is the wand. I mentioned my device is right here. So once a day in the beginning, just quickly interrogate the information, transfer it to a laptop. You know, it takes about 2 to 3 minutes to do, and you can transfer that data once a week over the internet. It takes about 2 to 3 minutes to do. So there's not much limitations on, you know, interrogating. With life, sometimes patients think that they have something in their head, that it's they're not going to be able to do things in life. I've experienced no limitations in my activities. You know, I do everything that I want to do. You know, I do encourage patients to talk to their doctors if they want to do something, you know, that requires headgear, or you know, definitely have that conversation with the doctor. But a lot of patients might think that they're going to be limited in what they can do in life. Another aspect of the RNS system is this small RNS magnet. So this is really useful for, you know, my device is here, so I'm not going to swipe it over the device. But let's say I was feeling an aura or a arm twitching, like I knew that that was the beginning of a seizure. I can take this magnet and I can slowly swipe it over the device. And what that does is it timestamps that moment and makes an EEG recording, a 90-second recording of that clinical seizure. And that was really beneficial for me early on for my doctors to see what was a clinical seizure versus a subclinical seizure. And so patients really like being able to provide the data, because having the power to do this kind of encourages them, enables them to be an active participant in their care. And that's really empowering because, you know, with epilepsy, a lot of times patients don't feel empowered, like they're being heard. And that's where something like a magnet or a seizure diary can really help a patient say, hey, I felt this. This is what was happening. And so, you know, there's that aspect with living with epilepsy. I know we're getting to the top of the hour, and I want to say thank you to everyone for joining us tonight. I mean, today. And, you know, there are some great resources available for you if you want to learn more about, you know, the RNS system. We do the second Tuesday of every month, we have an RNS community chat, which is the similar webinar as what we did today. You know, social media, you can stay up to date for events and, you know, updates with the RNS system. This is my contact info here. You can scan that QR code and it'll go into the patient educator form. You know, and you can reach out to me and we can follow up with you.
And I do want to mention, because if you, as Mike said, if you have the VNS, that and let's say the VNS didn't work for you, that doesn't mean that the RNS system isn't going to work. If you have a VNS and it has helped you, as I have a number of patients, I'm not going to stop treating my patient with the VNS. We just continue the treatment with the VNS and we add the RNS system. The other thing is, if you've had an epilepsy surgery and you've maybe benefited somewhat, but not enough, or maybe benefited not at all, you can still be treated with the RNS system, and your chances of doing well with the RNS system are not any different than for people who have not had a surgery. And then finally, the information from the RNS system sometimes tells the doctor that a surgery would be of additional benefit. Maybe they don't know that because they didn't get enough information during the evaluation, because, you know, with the RNS system, you have years of information. And so think about these treatments, medications, the neurostimulation devices amongst them, and surgery. They are not either or, they're all ands. And that's another reason why you need to go to an epilepsy center, because there are so many options. And it may be, in your case, as those options should be combined. And that really does require a physician who is experienced in all of these and really thinking about your situation and how to bring all the tools together to solve your problem to the best it can be.
Thank you, everyone. You see the next speakers are queued up. So, and thank you, Dr.
Bye-bye.
Morrell.
Thank you.